Hello, my name is Jennifer Cozart. I'm a cardiovascular surgeon at the Texas Heart Institute in Houston, Texas. I want to thank Texas Heart Institute and Baylor St. Luke's Medical Center for inviting me to speak today. I'll be discussing atrial fibrillation and the new approaches in management of this common disease, and I have no disclosures. A-Fib is the most common cardiac arrhythmia worldwide, and it affects more than 3 million people in the U.S. alone. A-Fib is associated with increased risk of thromboembolic events like stroke, peripheral ischemia, also reduced quality of life, and increased mortality. Persistent A-Fib is a significant treatment challenge due to the electrical and anatomic differences among patients, and this talk will focus on this form of A-Fib. A-Fib is less common in women, but women experience more symptoms, complications, and worse overall quality of life compared to men. Women with A-Fib also have an increased risk of stroke, heart attack, and increased mortality. Therefore, we may need to be more aggressive in treatment of A-Fib in women specifically. There are several different types of A-Fib I want to quickly define. Paroxysmal atrial fibrillation is A-Fib that resolves within 7 days of onset. I'm going to be speaking on treatments which target patients with non-paroxysmal atrial fibrillation, and the two types are persistent, which is consistent A-Fib sustained more than 7 days, and long-standing persistent, which is continuous A-Fib more than 12 months. This is an important slide that sums up most of what we need to know about A-Fib. The A-Fib risk factors shown here on the left induce structural changes to the atrium that then lead to fibrosis, inflammation, and cellular changes. These changes then increase the susceptibility to more A-Fib. Persistent A-Fib then further induces electrical and structural remodeling that promotes more A-Fib. Hence the term A-Fib begets A-Fib. A-Fib may also lead to the development of additional risk factors that further alter the atrial tissue substrate. Finally, A-Fib is associated with several adverse clinical outcomes like stroke, heart attack, dementia, CHF, and thromboembolism. And this slide shows why managing A-Fib or restoring normal sinus rhythm is very important. And the earlier we treat this or slow the progression, the better. When you think of A-Fib, you should think of stroke. An irregular rhythm causes stasis of the blood in the atrium and formation of thrombus. And that most commonly happens in the left atrial appendage, and then that clot can embolize into the systemic circulation and end up lodged in the brain, causing a stroke. A-Fib increases the risk of stroke 5-fold, and strokes related to A-Fib are typically more severe than those not caused by A-Fib. Primary treatment for A-Fib is medical treatment with rate or rhythm control and anticoagulation, but current research favors early procedural interventions to restore normal sinus rhythm and reduce A-Fib progression and complications. The procedural treatments for A-Fib consist of endocardial ablation, which is done by an electrophysiologist, and we know this is good treatment for paroxysmal A-Fib, but it's difficult to treat persistent and long-standing persistent A-Fib with this technique alone. The techniques I'll cover more today involve surgery. Traditional A-Fib surgery consists of the Cox-Maze procedure, which is still the gold standard of surgical treatment for A-Fib. It can be technically challenging and complex, and it does require cardiopulmonary bypass. It can be done through an open sternotomy or also minimal access. It does have a high long-term success rate at over 85% success at 5 years. Hybrid procedures are newer techniques which are a multidisciplinary approach combining both endocardial and epicardial ablation, which is both a surgical and an electrophysiology procedure, and it provides maximal treatment through minimally invasive off-pump approaches. Closure of the left atrial appendage is also a very important component in treatment of A-Fib and stroke prevention and can be done with other cardiac surgeries or as a standalone procedure. Surgical treatment of A-Fib was first performed over 25 years ago by Dr. James Cox in 1987. And this diagram shows the traditional cut-and-sew Cox-Maze 3 procedure, which is the basis of all ablations for A-Fib and remains the gold standard treatment for chronic atrial fibrillation. The full Cox-Maze lesion set is highly effective and it results in a high success rate, but it's rarely used today due to its high complexity. And this technique involved making multiple left and right atrial incisions and sewing them back together, and that then formed a set of scars which isolated the pulmonary veins, posterior left atrium, and the right atrium. The maze pattern was chosen to prevent multiple radical impulses from causing A-Fib, but also leaving the ability to activate both atria in normal sinus rhythm. This slide shows the lesions for the Cox-Maze-4, which is a newer version of the Cox-Maze-3, and it uses a combination of incisions and alternate energy sources like bipolar radiofrequency and cryoablations, and those devices are shown to the right, and they're used to complete the full lesion set of the Cox-Maze-4. This makes an easier, quicker, and safer operation with the same end goal instead of using all incision lines as in the Cox-Maze-3. This can be performed minimally invasive or through an open chest. It does require cardiopulmonary bypass and cardiac arrest. It can be done alone or with other cardiac procedures as well. And I'm showing this image as the lesion lines here are the basis for hybrid management of A-Fib, which I'm going to discuss. So hybrid ablations for A-Fib are a collaborative effort between an electrophysiologist and a cardiac surgeon to produce a complementary lesion set on the heart, both inside, which are endocardial ablations, and outside the heart, which are epicardial ablations. And combining the two approaches as a hybrid treatment, it's possible to replicate most of the Cox-Maze-4 lesions without cardiopulmonary bypass, which is a great advantage. And these off-pump, hybrid, minimally invasive procedures are much more appealing to patients and also referring doctors. And the types of hybrid ablations I'll speak about are the convergent approach or convergent plus and hybrid totally thoracoscopic maze. In 2021, the Episense radiofrequency device, which is the device used for the convergent approach, was approved by the FDA for treatment of long-standing persistent A-Fib. And this hybrid convergent approach is a team effort, again, with EP and cardiac surgeon. It consists of 2 procedures, staged 4 to 6 weeks apart. The first part's a surgical epicardial or outside the heart ablation with or without left atrial appendage closure. And the second part's an endocardial or inside the heart mapping and ablation by an electrophysiologist. The 2 targeted patient groups for the convergent ablation are those with long-standing persistent A-Fib or A-Fib more than a year, and those with persistent A-Fib who have recurred after failed endocardial ablations. So just going through the surgical procedure, convergent ablation begins with a transesophageal echocardiogram in the operating room to rule out any left atrial thrombus. If a thrombus is seen in the heart, then the case is aborted due to the risk of embolization and stroke. If the heart is clear, then we proceed with the surgery. A subxiphoid pericardial window incision is performed, and a cannula with a thoracoscope is placed in the posterior pericardium behind the heart. This video shows the surgical procedure. Through the cannula and the subxiphoid window, the scope and Episense radiofrequency device is inserted into the posterior pericardium. The device then creates multiple 3 centimeter linear radiofrequency ablation lines to completely cover the posterior left atrial wall between the pulmonary veins. One great benefit of this approach is that the ablation energy is directed away from the esophagus and directly toward the heart, which decreases the chance of esophageal injury. 4 weeks later, the endocardial mapping and catheter ablation is then done by the electrophysiologist to treat any gaps in the ablation lines or areas that weren't able to be reached by the first part epicardial approach. The completed lesion set for the convergent approach is shown here. The blue represents the epicardial or outside of the heart lesions that are done by surgery, and red are the endocardial lesions inside the heart, which are done for completion by the electrophysiologist. And the goal is debulking of the tissue that mostly commonly causes atrial fibrillation, and the entire posterior left atrial wall should be ablated. The end result is equivalent to the box lesion set from the Cox-Maze procedure with left atrial posterior wall and pulmonary vein isolation. In March 2021, the results of the CONVERGE trial were published, and it was a prospective, multi-center, randomized clinical control trial that demonstrated improved effectiveness of the hybrid convergent procedure over traditional endocardial ablation alone, especially in patients with long-standing persistent atrial fibrillation. The CONVERGE trial was conducted in 27 sites in the US and the UK, studied 153 patients with drug-refractory, symptomatic persistent, and long-standing persistent A-Fib. The patients were randomized 2-to-1 into the hybrid convergent arm and the endocardial catheter ablation alone. The left atrial appendage, of note, was not closed by any technique in this study. And the patients in this study had no prior ablations, so they had no prior interventional treatment to their heart. The CONVERGE trial imposed no limits on the duration of atrial fibrillation, and it also allowed patients with substantial left atrial dilation, which made it the only ablation trial to date which included patients with long-standing persistent A-Fib and those with significant comorbid conditions. The long-standing persistent A-Fib sub-analysis set showed excellent results and led to the FDA label in 2021 for treatment of long-standing persistent A-Fib with this technique. 42% of the patients in this trial had long-standing persistent A-Fib, and I'm going to show those results now. Freedom from A-Fib and at least 90% A-Fib burden reduction was significantly better with the convergent versus endocardial ablation alone, and this was sustained through 18 months. The diagram on the left shows that 71% of the patients in the hybrid group had A-Fib freedom at 12 months compared to 51% in patients with catheter ablation. At 18 months, this was sustained. So the absolute success difference of 20% is statistically significant in favor of the hybrid convergent group. Convergent patients also had 71% freedom from cardioversion compared to 41% freedom in endocardial catheter ablation alone at 12 months. And this graph shows that the A-Fib symptoms like palpitations, shortness of breath, and fatigue were significantly reduced after convergent ablation from baseline. So the dark bars show how much symptoms they had before the procedure, and at 12 months after the procedure, the lighter bars show significant reduction of those symptoms. So the results of the CONVERGE trial showed superior outcomes of the hybrid convergent procedure when compared to endocardial catheter ablation alone with drug-refractory long-standing persistent A-Fib. These results were sustained at 18 months, and there was significant reduction in A-Fib symptoms reported by patients. So the convergent approach was also proven to be safe, and a collaborative heart team approach helps to improve outcomes in difficult-to-treat patients with advanced A-Fib. The Convergent Plus approach, which is what I personally perform in my practice, is gaining popularity, and it produces further optimization against A-Fib. It includes the previously described convergent approach, but it also adds a left thoracoscopy with epicardial closure of the left atrial appendage using a clip. The ligament of Marshall can also be divided, which is a structure thought to be important in A-Fib, and an additional ablation line on the left atrial roof, anterior to the left pulmonary veins, and at the base of the left atrial appendage can also be added. The hybrid totally thoracoscopic maze is a newer minimally invasive technique for A-Fib that's more comprehensive than the convergent approach, but it is more complex. This diagram outlines the lesions which create the full Cox maze 4 lesion set through an off-pump minimally invasive technique. It does require a bilateral thoracoscopic approach to create the biatrial epicardial lesions. The left atrial appendage is also closed using a clip device, and the second stage endocardial catheter mapping and ablation is also performed to complete the lesion set similar to the convergent approach. A recent series published from the group in Chicago, including Pat McCarthy and Dr. Cox, reported excellent results with the totally thoracoscopic maze, with results showing 1-year freedom from A-Fib off antiarrhythmic drugs of 85%. And this procedure is not done in many centers currently due to its complexity, but I do expect that it will be further adopted in the future as the technique is refined. I just want to mention that left atrial appendage closure should also be an integral part of any A-Fib treatment because it reduces the arrhythmia burden and also prevents stroke and thromboembolism. And these images show the epicardial closure device. Approximately over 300,000 of these have been used worldwide, and it's very safe and effective. This can be surgically placed either through open surgery with other cardiac procedures or through a minimally invasive approach. And it can also be done as a standalone approach in patients who can't tolerate blood thinners through a minimally invasive left chest approach. I prefer this method of closing the left atrial appendage versus an endocardial plug because it electrically isolates the left atrial appendage, which further reduces A-Fib burden by approximately an extra 10%. So in conclusion, non-paroxysmal atrial fibrillation can be successfully and safely treated with minimally invasive hybrid procedures. You should always consider left atrial appendage closure during any hybrid treatment or concomitant cardiac surgery in patients with A-Fib, or as a standalone procedure when indicated. A hybrid team approach is an excellent way to optimize treatment and reduce the complications associated with A-Fib. New and emerging techniques are safe and effective for treating A-Fib and should be considered, especially for patients with long-standing A-Fib. And I want to sincerely thank the Texas Heart Institute for the opportunity to speak with you today. Enjoy the rest of the conference.